always helpful to figure out where people are from and the context that they're bringing as they bring their questions about the cleft surgery pathways in Wales. A brand new feature for the Circle of Cleft Professionals that we've never tried before. And so I'm so delighted when Matt Fell decided to step up and say, okay, sure, I'll be your guinea pig. I will put forward the Cleft Surgery Pathways in Wales document. And then so delighted to have my close colleagues, Dr. Nirina Mandrano from Madagascar, Dr. Francis TEGETE from Mwanza, Tanzania, to also provide some context and some questions, some responses in terms of this Surgical Pathways document. So welcome. If you're here to discuss surgery, cleft lip and palate surgery in particular, you are in the right place. If you've just joined, please do type where you're calling in from into the chat so we can get to know one another better. And this is an Ask Me Anything. Niti, what are we doing today? What is this call all about?
So this is the first time we're actually trying out the Ask Me Anything format of the session. So this is your chance to really, ask whatever you need from Matt, who's here, and also Dr. Francis TEGETE and Dr. Nirina, who's going to be here, and who's going to be moderating the session. It's going to be exciting.
Excellent. Well, thanks, Niti. So there are the lovely pictures that we have up there. And when Matt and I were talking about how to start this off, and I do see it's lovely, the interdisciplinary nature of the Circle of Cleft Professionals well represented. I'm seeing speech therapists. I'm seeing some surgeons. I'm seeing some others. Welcome, everybody. So glad you're here. But we thought we'd start off with, Matt, was just a quick overview of, this is the distillation of a whole bunch of work. So why don't we just start with saying, just quickly, Matt, I know this has been a 19-year journey. What started you on this journey towards surgery and cleft surgery in particular? And then we'll jump a little bit into having you have an overview of this document, some of the key points and decisions that you're making as the Cleft Surgery Centre in Wales progresses and as you've taken up your post.
Thanks, Hugh. Yeah, well, I've got some slides to give an overview of the decisions that I've made as part of the Welsh team over the last couple of months. But yeah, it's been a bit of a dream come true becoming a cleft surgeon 8 weeks ago. So I'm very new to the post, and I've been wanting to do it for the last 20 years. That's what I went into medical school 19 years ago to do. And yeah, it's a great privilege and a really exciting honor. I can't believe I can call it work to go and do it. It's great. Love it.
Thank you, Matt. Well, excellent. And I think just as we're getting started, it is a Welsh coastline that's behind you. But I think starting off with your overview, that'd be great to get us started. If you have come with questions and you've looked at this document, Cleft Surgery Pathways, then we will get around to that. If you have it on Circle, you'll see it is posted there. So even now, if you want to give it a quick scan, but Matt has graciously prepared a little bit of an overview of some of these key decisions that might spark some discussion. So Matt, over to you.
Okay. Right, is that coming through okay? Brilliant. So, yeah, so I've got slides which aim to take 10 minutes to show you, to give you an overview here. My name is Matt Fell. I'm a cleft surgeon at the Welsh Centre for Cleft Lip and Palate, and our symbol is there on the right of your screen, incorporating the Welsh dragon. And it's a great privilege to talk about the cleft surgery pathways that I've been thinking about very carefully with members of the team over the last couple of months in preparation for me starting 2 months ago. And here are some of the members of the Welsh team dressed in yellow for the Awareness Day for Mental Health earlier actually last month in October. And it's I'm so proud to be part of this team and to represent them today. So just to set the scene of what happens in cleft in the UK, for the last 25 years, cleft care has been centralised in the United Kingdom of Great Britain and Northern Ireland. And what centralised means to us is that there is a dashboard within the NHS, which is available via the link on the left of your screen. And this dashboard sets key performance indicators or targets for cleft teams to meet. And some of those targets are timings for lip and palate primary surgery. And centralisation also means that there is a contract set out by the National Health Service for what cleft teams need to provide and what they need to involve. And that can be found by the link to the right of your screen. And in the centre of the screen, there's a map of the United Kingdom. And this shows the 12 cleft teams that there are in the United Kingdom. And they operate out of 16 surgical centres, which are marked by the stars. And the Welsh team is the purple team in the southwest. And somewhat unusually, I'm the only cleft surgeon in the Welsh team, because most of the other teams have more than one cleft surgeon. And so most new cleft surgeons in the UK go in and they're under the wing of the more experienced cleft surgeon, and they tend to follow the pathways that are already in place. Whereas I had a rather unusual opportunity of being the only surgeon, therefore I could consider many of the decisions in the surgery pathway with the team and make a lot of those decisions. So that's what I want to talk to you about today and share that process. So this is a diagram to show my training journey. It's been 19 years since starting medical school in 2005 until I started as a cleft surgeon 8 weeks ago. And it's been different elements of going through medical school, starting medicine and surgery training, plastic surgery training, and then fellowship training in the last couple of years before becoming a surgeon. And that's been mostly in the UK, some of that abroad. And I've been very lucky to work with professionals all over the globe through organisations such as Project Hurrah, Cleft Bridging the Gap, for which I'm a trustee, and Transforming Faces, for which I'm an advisor. And it's a fairly standard training pathway I've taken with some deviations. And we've described what it sort of looked like to train as a cleft surgeon in the UK via this article, which you can access via this link here. And I do stand on the shoulder of giants. I've had so many people helping me along the way, and I'm particularly grateful to these 7 cleft surgeons who have trained me over the last 2 years in my fellowship before starting 8 weeks ago. So today feels like an amazing opportunity to share with you some of the challenging decisions that I've made over the last couple of months. It's amazing to have Francis and Nirina from Tanzania and Madagascar respectively to give their feedback and then to get all of your feedback on this. And I'm going to, it's all in the document that's been shared round, but in the next couple of slides, I'm just going to dwell on 5 areas that I've made decisions in with the team and that have been interesting to make. So the first area is in unilateral cleft lip reconstruction. It was fairly straightforward to me to choose the design of the unilateral cleft lip reconstruction, the anatomical subunit design described by David Fisher in 2005, because this is the design, the skin design that I've been taught by most of my trainers, and I've helped to describe modifications to this design, which is available via the link here. So that was quite an easy decision. But then I found some decisions very difficult. So under the skin, I found the decision of which plane to dissect in, whether it should be subperiosteal, that's underneath the protective layer of the bone underneath the lip, whether it should be subperiosteal or supraperiosteal above this protective layer. And some of my trainers had said it's damaging to growth to go underneath this layer, and you'll end up with problems. And other trainers said, oh, well, don't worry about it. It won't be damaging. And so I've decided to go underneath this layer, subperiosteal, because I haven't found any evidence in the literature that indeed it is damaging to growth. And I found that it seems to be a cleaner area of dissection, and it enables me to really move the nose and lip into a good position. So that's that decision that I've made. And then I found the nose very difficult to decide what to do with in these infants, because some of my trainers have taken a very conservative approach and have hardly touched the nose at primary lip reconstruction, whereas others have been very aggressive and they've done all sorts to the nose. And I really wanted to be able to do enough to the nose so that these children born with a unilateral cleft lip could go through school without the stigma of a very different looking nose. But I didn't want to cause damage to their nose that I'd then regret and they would also regret later on. So in all of these 5 areas of the nose, I've made decisions somewhat in the middle ground between being aggressive and conservative. So I've decided to centralize the septum. I've decided to dissect the tip of the nose. I think that's helpful trying to free up the cartilage. I have decided to put in some suspension sutures to try and lift up the lower lateral cartilage. I've used the Skoog stitch rather than the Macomb stitch because I've found that more effective. And I've decided not to open the nose because I thought that any scars on the sill of the nose would potentially cause problems later on. And I have decided to put stents in at the end of the operation, and I stitch those in for 6 weeks in the hope that that will mold the nose and give a better result. In terms of cleft palate reconstruction, it was fairly easy for me to decide on the technique to use. The intravelar veloplasty has been we've been influenced in the UK a lot by Mr. Brian Summerlad, and I'm convinced by what I've seen that it's a really good operation to do, and most people in the UK do that operation, so that was a fairly easy decision for me. But some of the more challenging choices were about at what age I should do the palate, and I was really influenced by the TOPS trial that has been published recently in 2023. I was really interested to see what those results were, and this link on your right is some work that we've done to really try and analyze those results further to see whether surgery at 6 months versus 12 months is beneficial. And the Welsh team originally did palate reconstruction at 6 months. And I thought that was a little bit young. I was a bit concerned at that. So we've agreed to do it at 8 months of age, trying to get the reconstruction performed before the speech comes in and before the children start babbling at about 9 months of age, but so that the children are a little bit more robust than 6 months of age. So it's been a compromise between the team members. And in terms of lateral relieving incisions, some of my trainers were very anti-lateral relieving incisions, saying it was damaging to growth, whereas others were very liberal with their use. And I suppose I'm relatively liberal. I've decided to have a low threshold for using them to try and reduce the amount of tension. In terms of the sequence of unilateral cleft lip and palate reconstruction, this was a fairly easy decision for me because it's quite established in the UK. For the last 25 years, we've been influenced by the Oslo team, and virtually all cleft lip and palate teams reconstruct patients with a unilateral cleft lip and palate in 2 stages in the first year of life. The first stage, the lip and the vomer flap for the hard palate, and then the second stage, the palate reconstruction. And we've shown this in the article via the link on your right. So that was an easy decision for me. I'm bought into that established UK approach. But the sequence for bilateral lip and palate was much more difficult for me because, having spoken to the UK surgeons, I reckon there's roughly a 50-50 split between half of the surgeons reconstructing in 2 stages in the first year of life versus half in 3 stages. And I was very influenced by my trainers in Oxford, who had looked at the complication profile after 2 stages and were quite convinced that they were seeing problems in terms of large fistula at the front of the palate after 2 stages, and that 3 stages was safer in terms of the complication profile. But it's been interesting talking with my anaesthetic team, because we've been talking about the safety of 3 anaesthetics in the first year of life versus 2. So at the moment, I've gone for 3 stages as shown here in this diagram, but I don't have evidence in the literature to know whether this is the right approach or not. Last couple of slides here then. So in terms of secondary speech surgery, as a new surgeon, I was very aware of my ability to cause harm in these patients in the surgeries that I might offer, in terms of restricting their airway and causing sleep apnea, and sometimes doing an operation that I didn't really know how effective it would be, a chance that I could do an operation and maybe not improve their speech. So I was very wary that I didn't want to cause harm to patients. So what operations should I choose that were effective and least likely to cause harm? And I've actually been very influenced by Oksana Jackson, a cleft surgeon over in America. Even though I've never been trained by her, when I've heard her speak about this, I've just been very influenced by her. So I've chosen a first-line approach of a re-repair of the palate with a furlough-type double opposing Z-plasty. And then as a second-line approach, these two operations, the buccinator flap and sphincter-like pharyngoplasties. So those are second-line operations that have a higher risk profile than the first-line operation. And lastly, I've been considering perioperative adjuncts and the evidence about the use of medications such as antibiotics. Before in Wales, all the patients had a week's worth of antibiotics after any cleft operation. And I've decided not to give any antibiotics after the operation. I do give antibiotics on induction at the beginning of the operation, but having discussed with the microbiologists and looked at the evidence, I don't think there's any evidence that I can see that antibiotics afterwards work. So I've stopped those. I do use a dose of steroids at the beginning of all cleft operations and give 3 doses of post-operative steroids after any palate operation. That there have been some randomized controlled trials, but it's not the strongest of data there. And I do use tranexamic acid for all cleft operations as well. And lastly, I've used local anesthetic nerve blocks, the suprazygomatic maxillary nerve block before any palate surgery. This link to the right of your screen shows a study that I've done, which actually shows in clinical use, there's no evidence that this block works. But I've got good experience of seeing that patients are more comfortable. So without actually any clinical evidence, I'm still using it, and I do think it's helpful. So hopefully that sets the scene. Obviously, it's, there's quite a lot of decisions that have gone into the surgical pathways, but I think those are the decisions that I've made that I've found most difficult, and now really look forward to hearing thoughts from Nirina and Francis about what they think.
Thanks, Matt. Very helpful overview. Lots of food for thought there. And so I have primed Dr. Francis and Dr. Nirina that just a few top line responses would be helpful. So Dr. Nirina, I see your video's on, you're right in front of me. So a couple ideas, first of all, just tell us a little bit about your surgical practice in Madagascar, kind of like Matt has, and how far you are into your career as a cleft surgeon. And then, well, let's talk a little bit about a few decisions Matt makes and what's different about your practice in Madagascar.
Yes. So I am Nirina. I'm a cleft surgeon of Smile Train since 4 years now. After medical school, I went straight to plastic surgery, where I had 6 years fellowship in a Cleft Center in Japan, in Tokyo, Japan. Then I came back to Madagascar in 2018. Then I started operating on the Smile Train program for about 5 years now.
Great, thanks. That's very helpful.
That's my pathway. And if we talk about Matt's surgical pathway that he was creating in Wales, this is very impressive for me to see somebody who is trying to put in place a different protocol from what others are doing. This is a very big chance. Then you have to review everybody's work to put your own decision on this. This is very exciting. So my experience, I didn't have this chance. What I've seen, I sent some comment to Matt before. What I've seen is like the 3 stages bilateral cleft lip and palate. That is something that will be very challenging to put here in Madagascar. Here, people are still afraid of anesthesia, even the anesthetist. So that will be difficult to convince people to do that. Anyway, having an evidence that it's work more on lip rather than on fistula palate, that will be interesting as well. If the lip have better aesthetic after that, because we will be talking about the muscle tension and something like. As well as using a vomerine flap on the primary surgery with the lip, how is that influence the bilateral cleft lip and palate? If we do it in a two-stage, would vomerine flap help reducing the palate surgery, first palate fistula as complication? And how do Matt use the tranexamic acid in his protocol? That is something that I would like to do.
Great, thanks, Nirina. We'll give Matt a chance to respond briefly, and then we'll have Dr. Francis TEGETE from Wanza to weigh in, and then we'll open up to the whole group. We'll see where the conversation goes. Matt.
Yeah, thanks, Nirina. It's really interesting to hear about the anaesthetic concerns, and it's certainly concerns that I share. And I think not only the anaesthetic concerns, but it's also been the burden of the three-stage repair on both the team trying to accommodate those three operations in the first year of life rather than two, and also the family having to come into hospital and go through three operations for these babies is also a big thing for them to take on. In terms of the role of the vomerine flap in a two-stage repair, there are surgeons in the UK are regularly using the vomerine flap in bilateral cleft lip and palate in the two-stage repair, and they use it in different ways. Some surgeons do a lip repair at the first stage with one vomerine flap, and then at the second stage come and do the palate and the second vomerine flap together. Whereas other surgeons do the lip repair and a complete vomerine flap on one side and an incomplete vomerine flap on the other side. So it leaves just enough vascularity, because of course the danger is that if you're stripping off the tissue on both sides of the vomer, that you're going to devascularize the vomerine bone and the premaxilla dies. And that certainly has been described. So, I mean, I think that's why I feel surgically it's much safer to do the three-stage approach, because there's no risk to the vascularity of the premaxilla, because there's only one side of the vomer done at one stage and then the other side of the vomer done at the other stage. But lots of surgeons in the UK and globally would disagree with me there. In terms of the tranexamic acid, I have been giving tranexamic acid on induction, so 10 milligrams per kilogram at the beginning of each case. And the literature on this is there in terms of there's a couple of randomized controlled trials looking at tranexamic acid. The thing is that their outcome measures have been pretty subjective. They've looked at how much blood there have been on the surgical swabs afterwards, and whether the surgeon felt that it was a dry field. So they're not very good quality randomized controlled trials in cleft. But I think in other areas of surgery, the evidence for tranexamic acid is pretty convincing, and therefore I think that it's a useful adjunct to use, and so I've been using it.
Thanks, Matt. That's helpful. And we are interdisciplinary on this call. Can you just summarize again just what the advantage, what the goal of your tranexamic acid is? What's the goal of using that? So
tranexamic acid is a medication, a substance used to reduce bleeding. So the whole aim is that you give it and it reduces blood loss and bleeding through the operation. The potential downsides is if it's going to cause too much coagulation, too much clotting, and therefore cause problems in that regard. But it's got a pretty good safety profile there. So I think if it can help reduce the amount of bleeding, which is one of the most terrifying complications after an operation, then in the mouth, such as a cleft palate repair, then that's a really useful thing.
Thanks, Matt. Very helpful. Nirina, one more comment?
Yeah.
Sure. Yeah.
Sorry. I usually tend to use tranexamic acid just after closing the wound. So the bleeding reduces postoperatively. How do you think about that?
I think that sounds epically sensible. I suppose the reason I use it at the beginning is so that I can have as dry feel during the operation as possible, so I can get control of everything and have, if I can see things really clearly, then I can be more confident at the end of controlling any vessels that are going to be problematic afterwards. So that's my thought process. For long operations such as complex rhinoplasties that have gone on over 3 or 4 hours, in my training we've given a second dose of tranexamic acid, but yeah, at the moment I've decided to give it at the beginning rather than at the end.
So I assume that you are using microscope. You operate cleft palate under microscope as Brian Summerland is doing.
Yeah, so everything under the everything intraorally. So for the palate, I'm doing under the microscope, and I've been so fortunate that the Cleft team in Wales have been able to purchase a new microscope for the beginning of my career with them 8 weeks ago. I realize how fortunate that is, and it really is a lovely piece of equipment, and I think it's been helpful for my neck and also being able to see. Do you have a microscope with you, Nirina?
No.
Yeah, that wouldn't be standard.
Unfortunately, I cannot. Unfortunately, I cannot use microscope.
That's
Yeah,
great.
thank you much. Thank you very much for your answer.
Thanks, Nirina. We might bring you back in, but I think it's helpful to name some of these differences in LMIC context and just what people have access to. So this is exactly what we're talking about. Dr. Francis, you've been listening with rapt attention, I'm sure. Tell us a little bit about your journey to becoming a cleft surgeon and your current practice, and then we'll ask for you for a few responses to what Matt's presented.
Thank you very much, Hugh, and my apologies, I cannot put on the camera due to the poor connectivity.
We'll imagine your handsome face. It's very easy for me to do so.
Thank you. So my name is Francis TEGETE, and I'm a plastic surgeon based in Mwanza, Tanzania. My journey to cleft care started since some 6 to 7 years ago, after I joined training in Uganda, pursuing masters of plastic surgery. So when I came back home, we saw an opportunity to start a comprehensive cleft care in Tanzania. And largely because we have at least 95% of the people who complete the cycle for comprehensive cleft care. And we now have at least 3 years since we started, and we are happy that we are pioneers in this country, and we are learning, and we're hopeful that we are going to give the best of care to the cleft patients. So I'm so excited to be part of this discussion today, and I must congratulate Dr. Matt Fell for establishing this pathway. He has done a lot of work with evidence-based information, and I'm sure the decision that he had put forward are going to be changing the game of cleft surgeries and care at large. However, I have read on the document and I've listened to him very well, and I think there are about 4 points which we may consider, as I believe this pathway is very much possible in low and middle income countries. So number 1 point is timing for surgery. We have learned that the UK standard would advise the cleft lip to be done before 6 months of age, and for cleft palate at least 13 months. So in low and middle countries, as much as we are guided by the protocols, by the funders, say we are working with Smile Train, that they put forward the guidelines. So there are some challenges we are facing in this, especially when we are looking for the patients in a hard way to come and help them out. So I think we need to put it forward clearly with evidence-based that despite the fact that we have to maintain the age limit, but still we have to be flexible on the agreement that even if I do this, say cleft palate that we are now doing at 9 months, still we can do at 8 months, and it makes a lot of sense. because you really have time to prepare a patient for speech. And when you come for cleft palate repair, then you can continue with your speech therapy very well. Number two, it's also, for me, it's really shocking to have these 3 stages. As Dr. Matt said, many people could not agree. But for us, the situation is a little bit different, that we prefer to even do a single stage because our patients are hardly to get to the hospital. Most of our patients are coming from very long distances, and a number of patients have poor socioeconomic status to travel to the hospitals and get care. But also we have very few centers with very few surgeons who can do cleft surgeries. So you can see that our practice has been to consider at least a single stage. So we do understand that there are some evidence that, like he said, for example, when you are going to play with the vomer flap, you may devascularize the vomer part, and then therefore it pushes you to do stages. So we think sometimes we can do at least 2 stages, and that it comes when I do the lip. I also consider to do the anterior part of the palate at the same time, at least to minimize the difficulty of the palate later on. So we may try to see if this surgical pathway has to meet the low and the middle income countries, as to also consider these factors that may be difficult to our environment. Another point is on the techniques. I really like the techniques he has put forward. A lot of work has been done by the surgeons that he has referred to. And I do believe that it's still based on the principles of what we want. And again, on the skills and the knowledge this particular surgeon has got before. And then we have a good time for a learning curve on the proposed techniques. Then they have to come out with more evidence and to convince a number of surgeons, especially the surgeons of old school, that we need to go to this way. So I agree with him. And another area which I think for the middle and low and middle income countries may be a challenge is the supply or the materials to facilitate the surgeries. Dr. Matt is using 470 PDS for the skin. I hope it's going to answer me why should we use PDS 70, but also microscope is a huge challenge. So some of the few areas of the facilities can be supplied, and we can venture to that. As a plastic surgeon, I understand using a smaller stitch to the skin, it improves on the scars and the outcome of the patient, including the appearance. So I think this surgical pathway is one of the documents that we are going to take also as a team and see how it can work in the environment. It's a really nice document, and I want to congratulate Dr. Matt well. Thank you.
Thanks, Dr. Francis. Matt, you've got some stuff to work with here. What do you think?
Wow, that was forensic, Francis. Thank you so much for having looked through everything so clearly, and you even picked up on the 7-0 stitch. So for the non-surgeons, the 7-0, it relates to the size of the stitch. So if it's a lower number, such as 1 or 2, it's a big stitch, and the higher the number, the smaller the stitch. So 7-0 stitch is and the PDS is the material, and it's a dissolvable stitch, but it lasts for about 6 months, so it hangs around for a longer time than a lot of dissolvable stitches. And in my training, I've seen a whole variety of different stitches being used for cleft lip, and people feeling very strongly about it. But I was very excited to see this particular stitch being used, because it's placed underneath the skin, so there is no stitch marks on top of the skin. So I'd seen a lot of noticeable stitch marks in children and adults as they grew as a result of having stitches put through the skin. So I was excited at this possibility of trying to avoid stitch marks by putting this dissolvable stitch underneath the skin. Because it lasts for 6 months, it would give a bit of strength rather than dissolving away over a couple of weeks like some of the other dissolvable stitches do. So that's my rationale, Francis, for using that stitch. I don't have any evidence in the literature that it's better than another choice or another stitch. I think the work that has been done comparing one stitch to another have pretty much all shown that you can't show a difference in the literature. But I'm excited by not putting anything through the skin itself. That really excites me. Yeah. And yeah, fascinating to hear you talk about the trying to do repairs all in one. I know that we both know Andrew Hodges very well, because I had the opportunity to work with Francis out in Uganda 5 years ago at the Corsu Hospital with Andrew Hodges, an inspirational cleft surgeon out there. And he's written before about the need to do cleft lip and palate all in ones because patients might not come back. And that is a challenge that in the United Kingdom we rarely have to consider, and we're not in that position. So that really is a really valuable insight. So thank you so much, Francis, for looking through it so carefully.
Lovely.
Thank you very much. And before I forget, could you comment more on the steroid use? We also give dexamethasone intraoperative and at least a single dose postoperative. Can you come more on the decision for a single dose?
Yeah, so I initially started in Wales 2 months ago with a plan to give all patients undergoing any cleft surgery a single dose of dexamethasone at the beginning of the case. And the aim of giving the steroid is to try and reduce the swelling from the surgery, which one would have thought is particularly useful for operations around the airway, because trying to reduce swelling around the airway, one would have thought theoretically is going to reduce problems with breathing afterwards. But I was also giving it for lip reconstructions. And then I'd made a plan to give it for all patients having anything inside the mouth, so any palate reconstructions and any alveolar bone grafts after the operation. And one of the anaesthetists, one of the very experienced pediatric anaesthetists, took me aside after the first list in Wales, and he said, "You are joking, aren't you? What on earth are you doing?" He said, you know, first of all, I don't think there's any evidence to show that this works in cleft, and second of all, it might interrupt the healing process. So I think you need to very carefully think about the pros and cons of giving this this steroid. So this was a great moment, because it was a really good chance to have get stuck in and have a really good chat with the anaesthetist about what we should be doing. So in the end, we decided to carry on giving steroids at the beginning of every operation, and only to give the post-operative steroids for operations on the soft palate. So only when I'm doing surgery around the airways to specifically reduce the risk of airway swelling. So I'm now not giving it for anything at the front of the palate post-operatively. So I'm not giving it after the vomer flaps, and I'm not giving it after the alveolar bone grafts. So I've changed my tack because of my anaesthetists raising concern that potentially it was a bit of an overkill approach. So yeah, I hope that explains some of the thinking.
Yes, thank you very much.
Thanks for walking us through that process. All right, Nirina, one last point before we open up to everybody else. Go ahead.
I would like to add a little bit about the steroid use. I am also using it for all my cases, even for primary palate, soft palate, hard palate as well. Every cases I'm using steroids. The thing is, like, my idea behind it is like the healing, as we say, is starting from about 7 days after surgery, but the inflammation is only for 3 days. So if you use dexamethasone before the healing process starts, that have a better outcome when you reduce the swelling during the inflammation time, which is only for 3 days, and then have a good healing later on. It doesn't interfere if you don't continue it over 3 days, my opinion.
Thanks, Nirina. Matt.
Yeah, thanks, Nirina. I think that makes a lot of sense. I've been influenced by a couple of trials that were done in India and America, and they showed benefits of giving cleft patients dexamethasone. Quite similar to the tranexamic acid trials, their endpoints were questionable. They were looking at time to feeding and whether there were any airway concerns after cleft surgery. And because time to feeding is fairly, it's not a direct link to swelling, and airway concerns are quite rare after cleft palate surgery, you can question whether those endpoints are the right endpoints to look for. And I think it's quite difficult to assess the efficacy, the impact of giving dexamethasone. But yeah, I feel convinced enough from the theory that you've just articulated so well, that it seems to make enough sense to me to give it. But yeah, I have altered how I give it post-operatively because of the chats I've had with the anaesthetist.
Nirina, thanks, Matt. Well, Matt, you brought with you a few members of your team, and so as we open it up now, and if you'd like to use the chat box or just signal that you have some questions, my first question is going to be to any one of your colleagues, just to describe a little bit what stood out in terms of this Cleft Surgery Pathways document for you, because as the Circle of Cleft Professionals, we are very interdisciplinary and team-based. So love to hear any of your colleagues to throw out a comment of what they've noticed or what they appreciate or what they're working through in terms of this Pathways document, or what you said. So Maha, Lisa.
Yeah, I can't stay quiet for very long, so I am going to say I haven't really put a lot of thought into it, but I was intrigued by what Matt was just saying about the 3 stages, because that's certainly not what we used to do. Well, I didn't used to do it, but the previous surgeons used to do it, and I get what he's saying about the blood supply, and I'm just thinking, thank God we didn't have any problems in the past. Because it looks a bit scary, if you're going to deprive the blood supply of both sides of the bone, then the risk is sounds huge. I'm no surgeon, I am just a neonatologist. So, but yeah, no, I really like that. And of course, steroids we use them very often for upper airway obstruction, and they work very well. I can see the point about you don't want to delay the healing as well. Like with fractures, I suppose you don't want to give people steroids then. So, but
Thanks,
yeah,
Maha. That's a great start. Very good. Lisa or Sandra, and then definitely we'll get to the rest of the community. Lisa, go ahead.
Yeah, so I was just interested to hear that Matt has decided to do his palate repair at 8 months. So with our previous surgeons, it's been 6 months. But I think listening to what Matt is saying, I think that's a really good balance, because he's still getting in before sort of the optimum stage for babble, but also just giving that little bit of extra time. So it'd just be interesting to, I mean, I wouldn't have thought they would make a lot of difference, but obviously we will be looking at the results as well in time. So it'll be interesting to see if there is any difference. So yeah.
Thanks, Lisa. And just for everybody else, you're a speech therapist, Lisa.
Yes, I am, yeah.
Excellent. Okay, Sandra, you got your video on too, so your last round, go around the horn, please feel free.
No, it's just lovely. It's so great to hear Matt be so open and say things like, you're not sure which way works, but you've been looking at the evidence here, there, and everywhere, and your aim is not to do harm. It's lovely. It's very refreshing to hear that, Matt. And I know very many people will be jealous of you having a microscope as well. So who knows what the difference makes? Is it the timing, 8 months, 6 months, 12 months, or is it having a microscope? But either way, I really look forward to hearing how well how the outcomes are for you in Wales, and I'm sure I'll be meeting up with Lisa about that. So yeah, good.
Great. Thank you. And Sandra, what's your discipline, Sandra? Just for the rest of the group.
I'm speech and language as well.
Okay, wonderful. Thank you. All right, to the rest of the community, what stood out? You've been eagerly listening, maybe you've been waiting to ask a question. What is your comment or question for Matt or for Nirina or Francis? All right, Debbie, please. Thank you.
I'm happy to to ask a question. I've got a couple of questions. So Matt, first of all, congratulations on actually that sort of distillation of the evidence into a document. I haven't had a chance to look at it, but just looked at how many references, and it's like, that is amazing. And, you know, a thinking, reflective surgeon is such a joy to hear. What I'm interested in, my first question would be, what is your plan for auditing or researching, and I'm interested for you perhaps to comment on that, your outcomes for the many elements of your protocol, and how that could be the sort of relevance if you're thinking of the lower middle income context, and maybe Nirina and Francis can also comment about that. So because it's such a big thing, and it'd be lovely to hear you. I'm sure you have a plan about how you are going to go forward.
Thank you, Debbie. And just for everybody, I think most people know, but Debbie's a speech therapist in the UK. Matt.
Well, thanks, Debbie, for having faith in that I've got a plan. I have got a plan. And the most of the plan is working with the team, who, I mean, the Welsh team are a fantastically cohesive, friendly and warm and highly functioning team that I've come into. And so they've got this incredible network and setup for looking at results, and have done that very well within the national structure. So I come into a well-working team, but I guess there are two things that we've been working on recently, which I think are exciting. The first is looking specifically at surgical outcomes and thinking about whether the surgery is working or not. So some of those outcomes are whether there's a fistula, a hole in the repair afterwards. That's an important surgical outcome. And I've been working with the NHS England team to create a tool specifically for surgeons to monitor their outcomes. It's a QSUM tool, QSUM meaning cumulative summation. And it's sort of gaining traction in surgery. It comes initially from the engineering industry, where they were looking at the pipelines of car making to see what the outcomes were. But these QSUM graphs enable you to put in your results and see over a period of time whether you're meeting your expected rates of complications, and whether you're in control as a surgeon or out of control. And the thing is that I don't think that to date there's been a freely, you can pay a lot of money to go on to software sites to make QSUM tools, but there hasn't been a freely available one. And a team of statisticians that we've been working with at the NHS England have created a tool, and we're now using it and trialing it, and we're going to make it available as soon as possible. It's going to be freely available for everyone around the world. So I think that's going to be an exciting development for surgeons. And then I guess the other exciting thing that I've been speaking about with the speech and language therapists in the team is how as a surgeon I can get feedback at the earliest stage to try and figure out whether my palate reconstructions are resulting in good speech. Because in the UK we have an important milestone at 5 years of age, where we audit nationally and our results are reported for everyone to see. But as a surgeon, it would be much nicer to get some feedback earlier than that, because I don't want to wait until 5 years to realize that things are not working. So that's been really interesting conversations working with the speech and language therapists to understand from their earlier assessments at 2 and 3 years how they can then feed back those early results in a meaningful way.
Thanks, Matt. Debbie, for me also, what really stood out with all of Matt's presentation was the reliance on saying this is supported by the evidence. This is my gut, but so far, but I'm hoping there'll be evidence coming. And so I think that was a great question for Francis and Nirina. Also, just quickly, you know, how how do you respond to this idea of how evidence fits in, and how is that part of your plan as young surgeons? And we'll get a very brief snippet from each of you, and then we have a surgeon from North Carolina who's gonna weigh in also. So Michael, I see you coming next. So Francis first, just that sense of how do you gather your team to look at and assess whether you're achieving the expected outcomes or not from the decisions that you're making in your surgeries?
Yeah, thank you very much. The evidence-based information gives us the best outcome of our practice. So I do agree very much with Matt and what he has put forward. It's all based on the information that has been gathered from the research done. So I think for the low and middle income countries is to look at the need assessment that will be similar to the practice done in high income countries, and see how we can collaborate together and have a sandwich program that we can try to use and see how this evidence information works as a pathway to our practice. Thank you.
Thanks, Francis. Nirina, anything to add from your Malagasy perspective?
On a Malagasy perspective, I mean, for now, we are only 2 surgeons that are trying to develop this CCC image of cleft care. So getting the team together to discuss about feedback, that is still a challenge for us. That will be, for sure, the main tool to use if we want to evaluate what we are doing. But for now, we didn't reach that level yet.
Thank you, Nirina. Helpful. Michael, what's your question or comment?
Well, thank you very much. First of all, Matt, brilliant presentation. The crystallization of your information is absolutely superb. And unfortunately or unfortunately, however you want to look at it, I agree with virtually everything you've said. And having been driven by David Keene at the University of Illinois, where I worked for 30 years, who's speech and language scientist, he drove me from the very beginning to incorporate outcomes of speech into everything we did. And if you had a kid or an adult who could not be understood, who could not function in school, you can do whatever you think is the best palate result, and it's a failure. And the only adequate outcome is not what it looks like, but can they speak normally? So I was driven by that one concept and have stayed with it all along. And one of our students, who's now the editor-in-chief of the Cleft Palate Journal, she's become quite a star as well, and working with all our MRI studies from the University of Illinois. So I commend you on this outstanding paper that you've sent along to us. I've devoured it and could find virtually nothing that I would argue with, other than I only give 1 dose of steroids, which you're doing now. And I only do 2-stage repairs for bilaterals, mostly because in LMICs, I don't want to risk anesthesia. And that's the other driver of mine, is reducing anesthetic risk. At Operation Smile, we're now really trying to dive into outcomes, and especially as it regards to speech. So we need to get surgeons information. We need to rely on our partners at the table, both in anesthesia and in speech science, to be able to make sure our outcome for palate surgery is adequate. So again, kudos to you. What a brilliant presentation. I'm so glad I had the fortune of our paths having crossed in the past. Thanks, Hugh, for putting this on.
Thanks, Michael. Wonderful. Matt, any responses to the last 2 comments?
Thanks, Michael. That's it's so lovely of you to say that. It means an awful lot. And yeah, it's lovely to work with you a couple of years ago, and really means a lot. Thank you.
So one of the comments is coming up, and I think we're hearing some limitations from both Dr. Francis and Dr. Nirina in terms of how far that's gone, but is that sense of a successful surgery leads to good speech. And I see some of the speech therapists on the call nodding, saying that is a primary assessment point. And that's also obviously in many LMIC contexts, there's ways to go. There are no trained speech therapists working in cleft in Madagascar at this point. Dr. Francis has one of the few in Tanzania, so there's obviously some potential there. But I think all of us working on the NGO side are figuring out how do we bring some of this speech focus as saying one of the key outcomes beyond a safe surgery, beyond making sure the parents have a good experience in dealing with some of the shock and potentially bias that they're experiencing, is that sense of that 5 years, as Michael said, are they able to fully participate in school? Is their cleft holding them back from living a full life? And that is maybe some of the training and other big parts that you've got in place in Wales, Matt. That's something that we're aspiring to, I think, in many contexts to move towards. Other comments or questions? We have some folks. I see audiology, even a few people I don't know. So if you do have a question, if you had a chance to look at this document, please, we've got a time for 1 or 2 more questions or comments. Debbie, back to you.
I'll have a question for you. And this is something that I think's really interested me over the years, is this whole idea of you as surgeons, you're with a lot of different surgeons over your training perspective, and then you have your evidence, and presumably as you go through that training, you'll be seeing things that you think, I don't agree with that, and yet that person is in authority and you're one of your trainers, and how much you have to sort of go with the flow, as it were, but it's now that you're able to do what you want to do. So I'm just that whole thing of, it's a very long training pathway and you're exposed to lots of different philosophies, but then you have your evidence. So over to you, Matt, to try and unravel my question.
Yeah, no, I think you're right. I think the ultimate decision is a mixture of what you've seen and then what you've read in the literature, and then sort of what you end up believing. And I think it's felt like such a great journey of training for me to be able to go through, and I've kept a very close record of everyone that I've had the fortune to train with, and what I feel is good aspects of that person's practice, negative aspects, and both of those positive and negatives have been useful, and tried to learn from that and create the end point, which is these decisions. I think it's been quite useful writing it all down in this document, though, because there are a couple of publications from very experienced cleft surgeons at the end of their career who have written down their pathways, and the examples of that are professor from Milan. Who was the professor from Milan? Risati, and then Talmont. Both wrote down their sort of philosophies at the end of their career, and that's so valuable to do. But I suppose trying to set it out at the beginning, right from day one, for me has been an interesting experience, and I suppose it will be one that I can then look back on, hopefully in 20 or 30 years, and say, oh wow, I can't believe I decided to do that, and I've learned subsequently that was definitely what I now think is the wrong idea, or maybe that I've chosen the right thing to do. So yeah, it'd be useful.
Thank you, Matt. Well, and that is, that's a great place for us to sort of keep drawing this conversation to a close. New ways of doing things. I think we've heard from Francis and from Nirina about how even this document in such an accessible format is shaping how they're thinking with their teams about how to approach some of these challenges. I think it also puts into context for us as NGOs, what kinds of tools and supplies and what kinds of questions do we need to ask if we're thinking about new teams that are moving in this CCC way, in this comprehensive cleft care way. And so one of the new ways we're thinking of doing this, along with Matt putting this out there so publicly, is allowing this conversation to happen in public. And so a huge thank you to our 3 surgeons who put themselves out there. And Niti's going to take us through a little bit, just very briefly as we end, about how you can make most use of this. If you have a colleague who wasn't able to be part of this, we have the recording. If you'd like to say, there's some great stuff in here we'd like to discuss, we'd like to hear about it on the brand new Circle platform. So Niti, what do we need to know? What are a couple tips about how to make effective use of the Circle as a way of stimulating this kind of learning and discussion among an interdisciplinary team.
For sure. And as all of y'all have logged in through Circle, I'm sure many of you are familiar with how the Circle functions. So what you need to know when you log in, you land on this page. On the left, you'll see the different sections. So for specialty focused discussions and interactions, what you'll need to focus on are these specialty resources. You would see that if you click on anesthesiology or surgery, you'll see a number of different resources that you can actually interact with. So there's different ways of searching for it. You can either search through media types, so journal articles, video, you can look for what you want, or you could search on the basis of topics. So if you're more interested in understanding simulators, NAM, you just click onto it, and then you have a whole list of resources. And to interact with them, all you need to do is click onto it, and then share your reactions or post a comment, and you can continue the discussion there. So on that note, if you really want to have discussions around specific posts that you put up, you can either join in through the Join the Conversation tab, or on the left, below the resources, you will see that there is a space for conversation. So if you click onto this, you will see that Matt has put up a post here. And this would be a great way to continue this conversation that we've just had. So if you would click onto it, and if you want to see more as to what the whole post is, you just click onto that, and then you can like, you can post questions, comments, and I'm sure Matt would be more than willing to continue this conversation and respond to questions even post the session.
All right, well, thank you, Niti. So that's true for every discipline, but especially true today for surgery. You don't need to be a surgeon. Obviously, if you have surgical-oriented questions, that's the place to join the discussion. I do recommend you check out Matt's post about the surgical drawings. It's very interesting. And not many people have explored it yet because of that next extra step. You have to click on the surgery, anesthesiology, and join the conversation. So that will what will keep propelling us forward. I do want to do a quick shout out also to another upcoming event. We heard earlier about Jamie Perry, the editor-in-chief of the CPCJ. She'll be presenting our next COCP webinar, talking about that whole idea of how we move in an evidence-informed approach in LMIC context. What have been some of the successes in terms of LMIC-rooted research? And maybe Dr. Francis and Dr. Matt, Dr. Nirina, you're gonna test out some of Matt's theses in your own context and tell us a little bit more about what's the evidence of this working or not working in an LMIC context, such as, one-stage repair, pros and cons. How does that work? It would be lovely to sort of see in someone else's future surgical pathway document a reference to your work in the CPCJ. So that's our hope. That's coming up. A huge thank you to Matt, to Francis, and to Nirina for sharing with us. Thank you for your questions and showing up. Please spread the word about this conversation that's recorded. Ask your questions, circulate this document, and together we're moving comprehensive cleft care forward. So thank you very much for joining us today, and we look forward to seeing you next time. If you have any comments or questions, please send them along. info@cleftcircle.org, and we'd love to know what you want to see in terms of your own learning and stimulation for comprehensive cleft care on this space. We want to be responsive. Thanks, everybody.
Thanks, everyone.